Hi, this is Shanna Howard. This is my advanced pharmacotherapeutics presentation, and I will be talking to you about migraine prevention. So today I will be discussing a hypothetical patient. Her name is Wendy, and she is a 30-year-old female who is presenting to my office with concerns about frequent migraines. She has a prescription for a triptan that she uses as abortive therapy. It does work for her, but her migraines have increased in frequency, and she's using 3 to 4 of these a week, and it is getting very expensive. She would like to talk about going on a daily preventative medication. She is already taking vitamin B2 and magnesium gluconate for migraine prevention, and they are not working for her currently. Her vital signs today, blood pressure is 129/78. Her heart rate is 85. Respiration 16. She is 99% on room air, and her temp is 37. So Wendy's past medical history is only her common migraine. That is migraine without aura. She had onset in her late teens. Her family history is significant for her mother having migraines as well. Her medications include a progestin-only birth control pill, which she takes daily, magnesium gluconate 500 milligrams daily, vitamin B2 400 milligrams daily, sumatriptan 50 milligram tablets taken at the onset of migraine, which she can repeat after 2 hours if needed. She also takes ibuprofen or acetaminophen as needed for migraines. She has no allergies, she does not use tobacco, and she does not use alcohol. So, social history, Wendy is single. She has a long-term boyfriend. She has an 8-year-old son from a previous relationship. She is a full-time student and works part-time as an office assistant. And she is considering having another child. So she is getting ready to finish school. Her and her boyfriend are discussing the possibility of getting married, and she would like to make sure that we select a medication that is not going to be harmful to a fetus should she get pregnant unexpectedly. So what causes migraines? All the theories on what causes migraines are just theories. We do not know exactly what causes them. Up until about 10 to 15 years ago, the thinking was that they were primarily vascular, that there was a vasoconstriction followed by a rebound vasodilation that caused the pain. That theory has fallen out of favor, and currently scientists believe that there is more of a neurological basis for migraines with vascular components. So there is a large genetic component to migraines. Therefore, it is believed that there is some sort of genetic abnormality that causes the neurovascular system of migraine sufferers to be hyperexcitable. There is a cortical spreading depression, which moves from the occipital lobe forward. And some scientists believe this is responsible for auras that some people experience. This depolarization activates the trigeminal nerve. It releases neurotransmitters which bind to receptors on intracranial blood vessels, and this causes vasodilation and a sterile inflammation, that is inflammation that is not caused by a pathogen. So this inflammatory process further activates the trigeminal nerve and transmits signals to pain receptors in the brain. The nerves become oversensitized, and normal functions that occur in the brain, like pulsating arteries or minor changes in intracranial pressure, become painful where normally they would not. So this is a very simplistic explanation of the pathophysiology theory of migraines. I did put in a link to a YouTube video that has a much more detailed and scientific explanation. It's kind of long, but it is an excellent video if you're interested in more of the pathophysiology. So in order to be diagnosed with migraines, a patient has to have at least 5 attacks, and their migraines have to consist of at least 2 of these 5 classic migraine symptoms. So most migraines are unilateral. They are often pulsating or throbbing in nature, and the pain is worse when the patient gets up and moves around, which is different than most other headaches. They are often associated with nausea and or vomiting, photophobia, and phonophobia. So the first thing I did was have a discussion with Wendy about migraine triggers. So these are common migraine triggers in migraine sufferers. This is not an exhaustive list, but they are often triggered by things like foods. That includes aged cheeses, chocolate, cured meats, artificial sweeteners, and processed foods often have additives like nitrates or MSG, which can be triggers, onions, nuts, alcohol, caffeine, etc. So in talking with Wendy, she does admit that she has been eating a lot more quick foods lately. She hasn't had a lot of time for meal preparation. She's been eating freezer meals and getting food out. And so she and I have made a plan where she is going to do some meal planning once a week when she has a day off, so that she has, freshly prepared meals at home as opposed to the quick foods out and about. She is under quite a bit of stress right now. She's a single parent raising a child. She's finishing up a degree. She's facing a lot of life changes in the near future. So she is under a lot of stress, and there doesn't really seem to be anything that she can do to reduce that right now. However, we did discuss fatigue. She's not getting enough sleep at night. She's staying up and watching TV instead of going to bed and that sort of thing. So she has committed to try to getting 7 to 8 hours of sleep at night. She does have some eye strain associated with her work as far as computers, and there really isn't anything she can do about that. She is not normally bothered by lights, noises, or odors. She hasn't really noticed any changes in her migraines with her menstrual cycle. She does skip meals, but we talked about meal planning, so she's going to address that, as well as making sure she's getting enough water and fluids during the day. So, in addition to lifestyle changes, we are going to start Wendy on a preventative migraine medication. So, all of these prophylactic medications come with side effects, and you can use some of those side effects to your advantage, and there are also conditions or circumstances where you would want to avoid particular medications. The chart on the right at the top shows some of the criteria for preventative medication, and Wendy definitely meets those criteria. She's having more than 2 attacks per month that interfere with her daily routine, and she's using abortive medications more than 2 times per week. So just for example, amitriptyline, if you had a patient who suffered from depression, that might be a choice for them, but you wouldn't want to use that if they had mania. Propranolol, if you had a patient who also had hypertension, you might want to think about picking that one, but you wouldn't want to use that if they had asthma or depression. Same with calcium channel blockers. And anti-epileptic drugs you would want to avoid in liver disease. So this chart shows that basically when you pick a medication, you start at the lowest dose, increase it gradually to the therapeutic range. If the patient is not getting effective treatment from that, you could consider combining 2 drugs or trying a different drug. So, on the right are I believe it's American Academy of Neurologists and the American Headache Society. And they released guidelines in 2012 for migraine prophylaxis. And basically what they did is they did a huge literature review, and they divided all of the commonly used medications into categories. So level A, they are considered established as effective, and level B is probably effective. So for the most part, I've talked about the level A medications from these guidelines. I did not discuss Butterbur here. So these are the options that I considered. Divalproex is an anti-epileptic. It is not recommended for women of childbearing potential. It is a teratogen. You would not want your patient to become pregnant while taking this medication. It also should not be used in patients who have any kind of hepatic impairment. There are black box warnings about hepatic failure with this medication. The next three are beta blockers. Metoprolol is probably the most affordable of the three choices, but it is currently off-label for migraine prophylaxis. So I did not use this medication for Wendy. Propranolol is actually the medication that I did choose. You would not want to use this in a patient who has asthma, which Wendy does not. It can also be used in pregnancy. And when I say it can be used in pregnancy, no medication is recommended to be used in pregnancy. However, if Wendy were to get pregnant while taking this medication, it would not be a very big deal. Most of the complications that beta blockers may cause in pregnancy occur in the second to third trimesters. So if she were to become pregnant, we would withdraw this medication over a period of a few weeks, hopefully before the third trimester. There are women, though, who take this medication throughout their pregnancy. It is approved to take for migraine prophylaxis in pregnancy. But it can cause things like decreased blood flow to the fetus and reduced birth weight and that sort of thing. Timolol, like propranolol, is a non-selective beta blocker. You would not want to use it in asthma. It is not recommended to be taken in pregnancy. I'm not exactly sure what the difference is, but according to the drug information, propranolol is preferred if the patient is pregnant over timolol. Topiramate is an anticonvulsant. It should not be used in patients who drink alcohol. It can also interfere with contraceptives, so it can increase or decrease the levels of estrogen or progesterone in the blood. So if you have a female patient, they should probably not be taking that medication if they are on hormonal-only birth control. This medication can also cause CNS depression. It should be taken at night, and if you have a patient who is having a hard time sleeping, that might be helpful for them. And it also has been known to cause or help with weight loss. It should not be prescribed to anyone who has an eating disorder. However, if your patient could stand to lose some weight, that might be an appropriate choice for them. It should not be used in those who are considering pregnancy, so we did not put Wendy on this. Amitriptyline is an antidepressant. It is actually in category B on the 2012 recommendations, but I included it here because it's pretty commonly used. And if you had a patient who was depressed, you might consider this medication. It is off-label for migraine preventative therapy, but this medication can also be used in pregnancy if the benefits outweigh the risks. So how do beta blockers prevent migraine? Nobody really knows. The connection was discovered by accident. When they started using beta blockers in the 60s, people noticed when they were taking them that their migraines significantly decreased, and they have done a lot of studying of this connection since then, and it has been found that they are effective in preventing migraines. It is thought that because beta blockers block the stimulating effects of epinephrine, that they may reduce the excitability of the nerves and relax the blood vessels in the brain. So, propranolol. This is a non-selective beta 1 and 2 adrenergic antagonist. It decreases heart rate, myocardial contractility, blood pressure, myocardial oxygen demand. Contraindications to this medication would be a hypersensitivity or allergy to this medication, heart blocks, or asthma. Adverse reactions include heart failure, heart block, bradycardia, arrhythmias or angina when stopped abruptly, Raynaud phenomenon, bronchospasm, and Stevens-Johnson syndrome. Common side effects to this medication are fatigue, dizziness, constipation, bradycardia, hypotension, depression, insomnia, and nausea. So there are quite a few drug interactions with this one. Most of them are other beta blockers or antihypertensives. Alcohol may change the plasma levels of the medication. And it should not be used with ergot derivatives. It also has interactions with certain SSRIs like fluvoxamine, and rizatriptan requires a reduced dose if the patient takes propranolol. So as far as the dose, we would start with 80 milligrams daily. With the immediate release variety of this medication, Wendy would have to take it probably 2 times a day. It can be taken up to 4 times a day, but we would probably do a twice daily dosing. So she'd take 40 milligrams morning and night. There is a generic extended release capsule available. So she could take 80 milligrams once a day. She would take that consistently with or without food and at a consistent time of day. The dose could be increased by 40 to 80 milligrams every 3 to 4 weeks, and the therapeutic range for this medication is 120 to 240 milligrams daily. If Wendy decided that she wanted to take it just once a day, the 120 milligram capsules are about $71 for a month. Alternatively, if she decided she could do a twice a day dosing, it would be about $12 a month for 60 tabs. If you compare that to the sumatriptan, there's variability in the prices that I was able to find for this, but for the most part, they're between $25 to $37 per dose. So Wendy is spending at least $300 on this medication a month, not considering what her insurance might be picking up. So as far as teaching, we want to tell her not to stop taking this medication suddenly. It should be withdrawn over at least 2 weeks. When she first starts a beta blocker, she might feel tired or less able to exercise. However, those symptoms should improve after the first couple weeks. If she has signs of an allergic reaction or difficulty breathing, severe dizziness or passing out, slow heartbeat, cold extremities, rash, or changes in her vision, she should call or get medical attention right away, whichever is more appropriate. And I did go over the expectations for this therapy with her. It will take between 1 and 3 months to determine if the therapy is effective. This may reduce her headaches by 50% or more, but it probably will not eliminate them completely. She is still able to take her sumatriptan for acute attacks while on this medication, unless she becomes pregnant. And that is the end of my presentation. Thank you for listening.